This is the area of the maximum gland, and this is where we try to suck without removing any fatty tissue. And then if you notice, there are small bulges here also. Those also need to be addressed. If we don't address after removing all these small bulges, they look very odd, and then definitely they do come back for a removal of this one, and the patient will be unsatisfied. So we try to do maximum gland and fat removal in this part, and only the fat part here and the fat part here by liposuctions. So this is the plan of the surgery. Yeah, today we are operating a case of bilateral gynecomastia in a 19-year-old boy under general anesthesia. I prefer under general anesthesia this operation because this liposuction part, gland excision, are usually a little painful, and not all people can tolerate under local anesthesia. That is, the other form of anesthesia is local anesthesia, where we give injections all around and make the area numb. Some people prefer that, but I prefer this way because it's more comfortable for the patient. And initially we have given general anesthesia with our anesthetist, and we painted this part with antiseptic lotion, and then we draped this, and this is the picture. And then we started infusing with the infusion bag, we call it, and with the saline mixed with the adrenaline solution and a little of xylocaine and sensorcaine also to make that area numb. And this is where we're good. We have infiltrated partly. And this is the small infusion cannula, and this is the pipe which is connected to the infusion bag. And under pressure we infiltrate, and then slowly we infiltrate this area with that normal saline mixed with adrenaline to make this area bloodless. Just like, because we do some amount of liposuction and some amount of gland excision also, because this surgery basically consists of both removal of the gland as well as liposuction to camouflage or prevent any shouldering effect. Because when we remove any part of the gynecomastia suddenly or gland suddenly, what happens is, if the gland part is more, there will be sudden depression in this zone and the periphery. So to camouflage, or rather to produce a good result, we have to do some amount of liposuction also. So this is what we have infiltrated, and then completed this infiltration part. Wait for a few minutes, maybe 10 minutes, and then we'll start this procedure. Initially we do with the liposuction, then follow with gland excision, and any further areas of fine tuning we do again with the liposuction. Now we'll start the liposuction process, and this is about 4 mm cannula at the whole side of the center, and this is a conventional liposuction, and not any laser or razor attached to it. I prefer the conventional liposuction. This is a tubing which is attached to a suction machine, and then we start with a small hole made in the inferior part of the nipple areolar complex. This is called the nipple areolar complex, and this is small enough to fit this cannula. So we don't make initially the bigger incision to remove the gland. We make a small incision and pass this cannula. And so our entire aim of surgery is to suck subcutaneously and beneath that is beneath the skin and beneath the gland also. Beneath the gland, pass through the gland and suck the surroundings also. So because in between there is a gland, and it is very difficult for the cannula to pass through the gland. So now we'll start the liposuction process, and this is about it. See this fat, pure fat, mixed with some amount of fluid that we injected coming out. In this case, surprisingly, the fat part looks more compared to the gland. So I think most of the job can be done by the liposuction. In some cases, last week we have done a case where it looks very thin build, and I expected not much of it. As I expected, there is a significant gland part, but not fat. So in this case, he's a chubby boy. So I expected more fat. So as per the expectation, he has more of fat compared to the gland. So the proportion of the gland and the fat varies with the type of the person.
Okay.